Hello, everyone, and welcome to the third webinar in our MDI myth-busting series. Today's myth is rapid toxicology screening tools can replace traditional toxicology testing. No need to confirm. We are joined by presenters Dr. Rob Middleberg, Core Laboratory Director, NMS Labs, and Bobby Joe O'Neill, Coroner for the Charleston County Coroner's Office. Without further delay, I will hand things over to our presenters.
Good morning, good afternoon, good evening, depending on where you may be. I'm Rob Middleberg, and I want to thank the organizers for inviting me today to present. I have a lot of slides to cover. I promise you I will get through all of them in a rapid fashion. I do want to start off by saying that while the gist of this talk may seem a little bit negative in respect to, I guess we could call it point of care testing at a coroner or medical examiner's office, there is a place for this testing. And it's a good place as long as it's used properly and everybody understands its limitations. And hopefully this presentation will go to that end. And I'm supposed to, the obligatory disclosures, I just focus on the last one. I have no others, but I am open to receiving stocks, bonds, and whatever else you might want to send my way. So with that, I thought I'd show you some headlines that a place you don't want to be. Anybody who's listening to this, classic mistakes in forensic toxicology that pathologists can make, medical examiners in America, a dysfunctional system, an erroneous opinion on a cause of death in a forensic autopsy case. That's not where anybody wants to be. And hopefully we'll all learn something today from what you're being presented that will hopefully avoid some of these headlines. So very quickly, just to get everybody on the same page, what is postmortem toxicology? Here's a big formal definition. And really what it is the analysis of tissues, fluids, whatever we can get from a body to help coroners and medical examiners determine a cause and manner of death. That is our job. And we use lots of tools to do that. So the expectations are at a high level, at least in the old days, that we would take our time, go through, all the things we had to do in a stepwise process. There really were no rules or standards to follow. And we would develop a method, run a sample. Now it's a good method. Maybe write it down on a piece of paper, maybe use a control, and then interpret the findings. Those were the old days, and life was certainly good then. But today, really, the basic premise has become it has to be good enough, it has to be fast, and it has to be cheap. And the old adage, pick two, doesn't stand anymore. All three of these have to be true. And the question is, can you really get there? And if you can, then woohoo, good for everyone. It'll be great. It'll be great. You'll notice a little fool up here. That is actually me in younger days. But I put the fool there on purpose to let you know that you got to be careful what you're doing. So again, we don't want to be in the headlines and we don't want to be fools at what we do. So what has led us to the point we are today? At a high level, the opioid epidemic. In the last 5 or so years, there have been over 500,000 deaths due to opioids and some other substances, and has made the headline for a long time now. Budget constraints. Can people really afford full-blown toxicology anymore? Turnaround time pressures. Feeble promises sometimes that are made to different offices about what can be done and really what can't be maybe is kind of held back. So let's talk about promises. Here is an example. This is Edison, Theranos' device that they came out with the big promise that with a single drop of blood, you can get hundreds of clinical test results. Well, it didn't really pan out. And in fact, these two people, Elizabeth Holmes and Sunny Balwani, the founder on the left, right-hand man on the right, are now serving pretty steep prison sentences for fraud, essentially, bilking investors for having a device that never really worked. So be careful of promises. So here's another paper that's out there, Magnificent 7 Errors in Forensic Autopsy Practice, the Italian context. And number 6 is conducting histological or toxicological analyses in non-accredited laboratories for forensic purposes. And that is at least in my mind, still to today, a taboo. So what is good scientific process in a toxicology lab? Well, certainly a chain of custody is important. You got to be able to do that. Ensure you're testing the correct samples. And that usually means checking a sample at least twice to make sure you've got the right sample. Testing schemes using broad-based screenings, then confirmations of those screens, and then getting quantitations. How much is there? And is it really important? Having a robust quality assurance and quality control program, and always doing continuous quality improvements along the ways. And also the main focus for us, since we are forensic people, which means of or related to the law, is what we're doing going to pass legal scrutiny? Because if it doesn't, there's going to be an opposing expert, of which I am many times, to come and controvert what somebody else is trying to say. So here's some more headlines. Coroner saves money in drug overdose testing, postmortem toxicological urine screening, and cause of death determination, which we know as toxicologists can't be done. Coroner's office buying rapid toxicology analyzer to expedite test results. New toxicology machine to benefit coroner's office overdose practices. Now, again, I'm not saying these devices are bad. All I'm saying is you got to know their limitations, and that's what we're going to spend the next several slides talking about. If all those things were indeed true, right, we could all go, woohoo, less work to do, longer lunches for everyone. But the reality is it's not true. It just is not. As Beverly Hills, the great opera singer, once said, and I'll get back to this at the end, there are no shortcuts to any place worth going. And I think that's true even in our forensic sciences. So what are screening technologies today? Well, we have immunoassays, we have GC, MS, and LC time of flight, and other forms of mass spectrometry. Immunoassays are generally the basis, some form of them, for these rapid analyzers or cups that you can put urine in. There's a whole host of point of care devices. Again, I'm not saying they're terrible. All I'm saying is you got to understand their limitations. They're usually very simple, maybe a simple button push, very little sample prep, if any at all. But you do have to understand there's a higher chance for false positives, more blind spots that you may not see. They may be susceptible to interferences and different cross-reactivities, which I'll get to in a second. And generally qualitative, you get a positive or negative, not really very much quantitative information. In other words, how much of something is there. And they are less expensive. GCMS, LCMS, LC-TOF, those things, again, they're laboratory-based testing that requires sample preparation, longer run times, broader in scope. You'll get hundreds of different compounds at one time, generally very sensitive, but they are more expensive. So I'm going to show you some slides. I'm not going to go through all the information on all of them. We'll run out of time. But the kinds of things, some of the things you have to be aware of. And here's a paper that was written about the evaluation applicability of rapid postmortem urine drug testing at autopsy. And some of the conclusions: accepting presumptive results as the singular toxicology contribution to determinations of death negatively impacts the individual case and the quality of the agency's work product. That's an important conclusion here, and you need to take it to heart. I can tell you as a toxicologist, urine cannot be used as a causative or a specimen that leads to a causative toxicological impact on death. So what are these things called cross-reactivities? You may have heard this term before. And here's an analogy that one could use. And I'll read, this is the one slide I'll read through. A good analogy for explaining cross-reactivity is comparing it to a security checkpoint at an airport. Imagine you have your immunoassay as a security checkpoint designed to detect a specific type of passenger, or in our case, a drug. The security system, again, the immunoassay, is trained to recognize and allow only passengers or drugs who match a very specific profile to set off the alarm. Cross-reactivity occurs when the security system mistakenly identifies and flags passengers or drugs that look somewhat similar to the intended ones, but are actually different. The system will have variable degrees of success in identifying threats, depending on how closely they resemble the passengers the system was trained on, missing some threats and incorrectly flagging safe passengers. And that's what happens in a lot of these drug tests, especially point of care tests. To give you some examples about cross-reactivities, when looking at designer benzodiazepines, which are around a lot today, you could see anywhere some compounds having 263% reactivity with the test, whereas others are down to 36%. And there's a lot of things in between. So you might miss things at this end, get hyper reactivity on this end, and everything else is all over the place. Another one for benzodiazepines, you can see where things fall. Again, you get this broad range of responses. Well, using LC-TOF, or time of flight mass spectrometry, which is a device that allows you to see hundreds of compounds all at one time, you get to see these expanded panels of things. The responses are set according to a threshold. And the pros to this are it's more sensitive. You get a lot more data. You're likely to find more things than you ever would on an immunoassay, but it is more expensive and it takes a little time. Now, time is something that's relative. In the old days, we could take months to do toxicology. Today, results are generally ready between a week and two in a lot of places, including the lab I work. So when you look at some of the results, we did, in fact, and you look at 354 cases, there were 57% where one or more additional substances of forensic significance were detected under LC-TOF. In other words, if you did an immunoassay and it only detected opioids, we found a lot more things. And on average, 5.5 additional findings. 114 different drugs not detected by immunoassay were identified through the TOF. And remembering that the job of a coroner and a medical examiner is, to a large part, public health, not finding these other things really can get in the way of aiding public health. Some other tests showing, what cannot happen potentially with immunoassays. You look at fentanyl analogs and designer benzodiazepines, compounds like xylazine that's in the news all over the place, and fluorofentanyl, generally compounds that won't be picked up on immunoassays, yet very important. Some specific cases, a 30-year-old female with no known case history, delta-9 THC, seems simple, might be picked up on ELISA only. But when you do the rest of the testing, what you find is a cause of death is the antidepressant bupropion, which you will not pick up on the immunoassay. So you will have missed a cause of death in this case, and maybe signed it out as no toxicological input or import. 27-year-old male suspected overdose. Again, THC by ELISA, the immunoassay type test. But when you look at everything else, you see all kinds of things present in this person, including protonitazine, one of the new synthetic opioids that's out there. And compounds like that are causes of death. 40-year-old female, fentanyl, very low amount of fentanyl here. But when you do a broader screen, you find fluorofentanyl, xylazine, in addition to the fentanyl itself. So again, this is a concentration that probably doesn't represent a cause of death in most cases, but without these other findings, you might not have had a cause of death. So the conclusion on this type of a slide, and I'll only read the yellow, only drugs present in concentration sufficient to have caused or contributed to death should be listed on the death certificate. And this comes from Vital Statistics, the Vital Statistics Reference Guide. And if you're only doing these point of care tests, you're not going to generally get reliable quantitations. So there are regulatory requirements today that these point of care devices will not meet. The American Board of Forensic Toxicology, for example, positive results from immunoassay screening tests must be confirmed by another more specific method, such as mass spectrometry. If you're signing out cases again based on immunoassay, you're not getting this. Even from the Forensic Toxicology Center of Excellence, who is hosting today. False negatives and false positives are realities of screening tools, and many offices feel uncomfortable using screening results on death certificate without appropriate safeguards, and so forth and so on. So again, these are not things that are being made up from agencies that really don't have knowledge. They're telling you exactly what this should look like. The National Association of Medical Examiners, conclusion they've reached: screening tests alone offer generally incomplete evidence and are subject to false positives and are thus inadequate for establishing cause of death. Again, back to our headlines, you don't want to be caught after you're doing this in those other nefarious headlines. So it brings up ethical concerns. Do we have to be concerned? It's the traditional cookie jar. Mom says you can't have a cookie before dinner. The little girl's looking, they sure look tempting. We also always have this, right? We have our little angel in one hand, devil in the other. I could save money over here, get things done really fast. You're not doing it right. You're not doing it right. The angel is screaming. Standards for identification criteria in forensic toxicology out of the OSAC within NIST. It's a point scale on how something can be reported as positive. You're never going to hit this point scale, the minimum points that you need to through immunoassay and other screens. The other simple way to look at it is, can you do forensic toxicology really with a single club in your bag when you play a round of golf? Well, I don't think you're going to putt very well with your driver. You need the whole armamentarium of clubs in order to have an effective round of golf. And it's no different that you need all these clubs to do forensic toxicology correctly. So we come to this. There's a right way to do things, a wrong way, and it depends, but not really. There's a right way to do things. And I think people need to understand that. And here's the headline: faulty drug testing may have falsely convicted thousands in, I won't tell you where. So my recommendations to you are: make sure you know where you're headed and the pitfalls of where you're going. Understand the limitations of what you're using and what to do about that. Budgets are one thing, justice is another, and nothing was ever accomplished by being a bobblehead. And that's me as a bobblehead. So again, I'll leave you where I started. There are no shortcuts to any place worth going. With that, I'm going to stop sharing my screen and turn this over to Coroner O'Neill.
Well, hello, everyone. Thank you, Rob, for kicking us off on a good start. And so I'm going to talk coroner. So I am one of those coroners who is using a rapid toxicology screening tool. I'm the coroner in Charleston County, South Carolina. And I'm going to tell you the pros and cons and what we've learned and how we are using it. I will tell you that I have one of the same problems that some of you probably have. So we are seeing a backlog in toxicology testing, and that's a backlog in getting autopsies done and therefore death certificates, and how we are able to sort of quickly determine cause and manner of death on a case. And so some of the solutions that we're trying to come up with to fix this problem have to do with doing rapid toxicology. And so our offices, like mine, are resorting to solutions in order to fix this problem. Some of the benefits for rapid tox: immediate results, as Rob mentioned. It also can guide autopsy decisions. And so one of the ways that we're using it is when we have a suspected drug overdose, but we also have somebody with a lot of comorbidities, we can screen them. And if it comes back negative, it may help us make a decision that we will or will not autopsy. That can be a benefit. It can also be a benefit to do quicker turnaround times for getting death certificates completed and getting results back. It also helps us with data for public health. So the information that we may provide to our law enforcement or our public health agencies or our agencies who help with substance use disorder and getting information out to communities. That can be a benefit. A con, though, are resources can be intensive that are needed for rapid toxicology. There's also low specificity, which Rob mentioned, and that you still need to do an autopsy to confirm other findings. So, for example, the problem sometimes with rapid tox is it can be resource intensive. Some of the units are expensive. The supplies are expensive. Annual maintenance fees to maintain that equipment. You also have to have the personnel to run the units, and then a way to manage data. And so that can be a negative to a rapid toxicology system. The low specificity, again, was mentioned by Rob, and you're going to get more false positives. Some agencies are not conducting autopsies and confirmatory testing that are specific to drugs. And so the problem you can have with these units is you also don't have interpretation. So one of the things that if you're using a rapid toxicology system, whatever it may be, whether it's urine-based, whether it's like a Randox system, anything of that nature, you don't have interpretation. And that can be a problem because if you do not have a toxicologist in-house, or you're not using a forensic pathologist when you're drawing this tox, then you are missing information from an interpretive standpoint. That can cause us to have an incorrect information on death certificates. And then we also miss detection and surveillance for our drugs that are novel and new and synthetic, sort of like xylazine. So a couple of, I have on a screen kind of comparing rapid drug screens to lab tox screens. And sort of the differences in timeliness. Obviously, your rapid drug screen is immediate, whereas your labs can be months sometimes, depending on whether you're using a state lab or a private lab. The results oftentimes with the screens are just qualitative. They're positive or negative, whereas if you're using another lab, you're going to actually get the quantitative results. The testing sample, many times the rapid, you're only using urine and blood, whereas with the other labs, you can have other samples that could be tested. Those are differences. Also accuracy, there are some false positives and also false negatives that can happen with rapid units, which you do not see as much when you send off to the laboratory setting. The threshold, as Rob mentioned, is different. And they aren't, that can really impact what you're finding. And so from my perspective as coroner, I want to make sure I find everything because I'm a matter, not only do I have a criminal justice standpoint and part of that role, but my public health role, but most importantly is to get the cause and death right and get it correct on the death certificate to make sure our public health data is correct. I mentioned the interpretation with rapid units. You don't have somebody helping you with interpretation. So if you're not a toxicologist, you're not a pathologist, you may very well miss information. And then the cost. So with a rapid system, sometimes the cost could be lower, but depending on what you're using, it can be just as expensive by the time you have your personnel and so forth that are managing and working on those kinds of units. Again, the threshold is different, the cost is different. There's a lot of pros and cons. I want to mention a couple of studies that were done by King County in Seattle. They started using the Randox toxicology, rapid toxicology analyzer, which is the same that I use in my office. And they started a program where the way they used it was they created a rapid death certification process. And so they came up with 8 criteria on what they consider to be a possible or probable drug overdose. And in order for them to use the rapid toxicology system, they had to have meet 2 of those criteria. I'll read you the 8 criteria just so you know what those are. No primary cause of death. The second is the clinical signs of an overdose. The third, suspected illegal drugs that are present. 4, paraphernalia present on scene. 5, evidence of a prescription history where overdose could be a risk. 6, a history of illicit drug use. 7, hospital drugs that have a high level of potential overdose associated with them, or any other evidence that may lead them to believe that they may have a drug overdose. So if they had 2 of those, they would do their rapid death certification process where they would test the sample. And then after testing that sample, they would go ahead and sign the death certificate based on the testing from the rapid drug testing. The problem is that they still sent off for confirmatory testing. And so the number of times that they'd have to change or amend death certificates isn't part of their studies. I'm going to talk about what we do in Charleston. We're similar. However, we went ahead and did rapid drug screening on all of our autopsy cases and anything that we were worried about tox. And we wanted to try to screen out as best we could. And then rather than signing the death certificate based on that rapid toxicology results, we went ahead and pended our death certificates, and then we send off for confirmation. And I'm going to show you some of those stats in a moment. What we did find is that by having the rapid unit, it did a couple of things. One, it let us know whether maybe our suspicions were right or not. It allowed us to provide information to families of what we thought we were finding. Again, it was presumptive based on the testing. It also gave us the opportunity to notify our stakeholders, law enforcement, our public health system, who is providing services for those with substance use disorders. It had a lot of benefit for us from a public health perspective. And in that regard, this was very successful, and I very much like the use of the rapid toxicology system. And so far, we've had the unit just about 2 years. We've run 142 Randox tests on the unit. We started with just qualitative, which is the multi-stat. And then we tried the quantitative Tox Plus system for a while. However, we stopped using it because we were getting so many false positives. And so right now we currently are using the multi-stat for screening purposes only. The multi-stat gives false positives, but it's more manageable since it's qualitative. So far this year, we've done 180 tests in 2024. 4 tests failed due to probably inadequate sample. Sample could be a little more decomposed than is probably good for the unit. And of the 180 that we've done so far this year, 144 of them have come back where we sent off for confirmatory testing. Of those, we relied on the Randox or the rapid tox if we had relied on it for our death certificates, 72 of those would had to have been amended. That because they were either had false positives in them or they were missing analytes. Now, some of you may be going, what was the cause of death right in the end? It was a drug overdose. Yes, we only had 4 cases out of the 144 where we would have got it wrong. The question is what percentage is okay? What percentage is okay to get wrong? Well, with the families that I work with, 0% is the right amount. So as we go back and look at our numbers again, so 72 would have had to have been amended. If we take out all of the ones that had benzoglycanine in them as a false positive, which we know that is an error that we see often, that still would leave us with 53 death certificates that would have needed to be amended, or 37%. And that's a lot. Now, the question becomes, well, it's just amending a death certificate. It's just signing a death certificate, but it's not. It's not only is it amending the death certificate, it's amending the autopsy report. It's also a matter of notifying families. So in my jurisdiction, if we make a change to a death certificate for whatever purpose, we're going to notify that family that we've made that change. If we have 4 cases where we had it wrong based on rapid toxicology, whether we had it wrong, it was a natural, and we changed it to an accident, or whether we had it wrong, we'd put it as an accident, and now we're changing it to a natural. What we just did is we just caused a family not to trust us. We just caused them to doubt everything else about our investigation. And I, for one, don't want to be in the news for that. Just as Rob said, I want to make sure that our confirmation is right and that we have it right the first time. I don't want in my office to go back and be amending. So let's talk about some of the limitations that we've noticed with false positives on the unit that we're using. And it's very common to have a false positive for benzoglycanine. And for THC, we've had a number of false positives. With the Randox so far, we've had a couple false positives with fentanyl, where it came out as a positive fentanyl, and when we did confirmatory testing, it was negative. Now, it possibly could be that that was related to user error or a problem with the cartridge. However, we didn't know what the problem was, and had we not done confirmatory testing, we would have had those wrong on the death certificate. That's wrong information for families. That's wrong information for insurance companies. It's wrong information for public health. As we look at false negatives, there is a limited ability for the system to recognize low concentrations. So we had a couple of cases once we send it for confirmatory testing that we had methamphetamine and other drugs on board that were just at low concentrations that the rapid unit did not pick up. Again, as we look at making sure we have it right on first bounce, and we have all the information on the death certificate that we believe contributes, those would have been errors that we would have missed. Also false, the limited panels. So, the multi-stat, which we use currently, has a limited panel, although we're working with them to try to expand those panels. We would have missed new stuff like xylazine. We would have missed those drugs. And that's a big, important player as we look at public health and providing the right data to our stakeholders. The other thing is it tends to cluster drugs into classes. So Rob mentioned benzodiazepines, and we saw that as well, where we would have a positive for benzodiazepines, but it doesn't break it out into which ones. So once we would do confirmatory testing, we would see that breakout, which could be very important, again, for cause and manner of death, and also from a public health perspective on providing data regarding those deaths. I do want to share a case with you where our rapid tox made all the difference, because as Rob said, this isn't a right or wrong, it's a pro and con, and it's a making sure that you understand the value, benefit, positive and negative for using it, and understanding the weaknesses. But we had a pretty big case here back in May of this year where we had a 10-month-old who died. And through that investigation, it was all of the interviews and all of the doll reenactments and everything were leading specifically our law enforcement to think that we were looking at some sort of a rollover death of some type. However, when we did a rapid screen, the baby tox came back as positive for fentanyl. What that did is it sparked law enforcement and the coroner's office to immediately do some additional investigation. We grabbed obviously all the bottles. I mean, we had a lot of those already in custody. It started the testing of those bottles. It started the testing of formula that was in the home. It had us look at other circumstances surrounding this family. Mom had a drug history, but having that quick fentanyl result in a rapid toxicology system put us all in alert and had us start moving through a process that we wouldn't have probably done otherwise, with tox being delayed 6 weeks. This made all the difference. Further investigation revealed that mom had prior overdoses. She'd also had prior incidences with child neglect. We found fentanyl in the formula. We also found it on the pacifier. Again, this is just an example of where rapid toxicology can really help you investigatively. However, I also mentioned to you a few minutes ago that we had situations where we had false positives for fentanyl. So you also want to make sure that you recognize that just because you had it, you need to confirm it and verify it. We would have never signed this death certificate out due to fentanyl without confirmatory testing, and I'm really hopeful that no one else on here would do that as well. So how do we improve? Suggestions for how to improve rapid toxicology systems. Again, we've worked with our vendor to try to change the customized panels based on what we're seeing in our community. There may be other ways to use it. I've heard of folks who want to draw tox at the scene, go ahead and release a decedent to a funeral home, and then make decisions. That's not how I want to do that, but I think that there are pros and cons to that. You still need to do confirmation testing, and I think it's best to bring in and follow the guidelines that if you're suspecting an overdose, that we do that full autopsy and full confirmatory testing with tox. And then to just develop more partnerships and follow the research on where this is going. I'm just like you. or many of you probably, I run an office. I have a budget. I have time constraints where families are wanting answers. I have the media calling just like you. I have those same concerns that you have. And so the way that we are using it is that to qualitatively check, to help us screen, to make sure that it helps us investigatively and we provide that information to public health. But in the end, as the topic says, is it a myth that you do not need to do toxicology confirmation? It is a myth. You do need to do confirmation on every single one of them. I highly recommend that. And I think our numbers show why that's important. I just, again, want to end with, I am a proponent of rapid toxicology. I have a unit in my office. We use it every day. However, I am also a proponent of making sure we follow the science. We make sure we get it right on the first bounce. We don't go back and amend things because that just loses the public confidence. And if you're like me, I want my public to stay confident in what we do here. And so we will continue to do confirmatory testing prior to signing any death certificates. And with that, I am glad to take questions.
Yes, thank you both so much. My name is Erica Christensen. I'm going to be moderating the Q&A session moving forward. So please continue to submit any questions you may have using the Q&A pod below. Rob, Bobby, thank you again for your presentations. Very, very informative. To kick it off, our first question is, can you guys expand a little bit more on why post-mortem urine toxicology results are insufficient?
Well, I'd be happy to do that. It's actually one of the basic tenets of postmortem toxicology that you can find in texts and manuscripts all over the place, because urine is a waste product and things accumulate in urine over time. So somebody might be exposed to a drug substance, say cocaine, 3 or 4 days before you draw a sample, a urine sample, and they probably would still be positive. And that's true for a lot of things. For marijuana, for example, it could be a week or more, depending on how frequently somebody uses. We also know there's no way to interpret the numbers that come out of urine. They're all over the place. It can be high, it can be low, and it doesn't really mean anything whether it's high or low. So again, urine, a waste product, things accumulate in it. You will find things in urine and no longer find them in blood. That's pretty frequent. So that's why almost every state, except one that I'm aware of, won't allow you to use urine for even DUI cases, driving under the influence. No true interpretive value.
Excellent. Thank you for that. Bobby, did you have anything to add regarding that topic or case experience?
Nope, I think you got it.
Perfect. Excellent. Our next question, can you explain a little bit more about the benzoyl-guanine, sorry about the pronunciation, but result in the infant overdose case, Bobby? Is this one of these cross-reactivity false positive results?
So the infant case that I showed?
Yes. Can you explain the benzo result that you saw in that
benzo
case?
result? Yeah, I don't have the tox result in front of me. The main issue was obviously this fentanyl that just caused us to go down a different line investigatively. When we were at that scene, I actually responded to that one. I will tell you that it concerned me, this whole scene. It didn't seem like an overlie to me that there was something else going on. Had we not had the ability, though, to do rapid tox, we would have sent off. We would have been waiting. If y'all know, sometimes law enforcement doesn't go along with you and they want to wait till everything comes in. Hope there's not too many law enforcement that's watching. But with the rapid tox, we were able to immediately go, uh-oh, we have a problem. And it was matching some of the things that we were seeing as far as some of the risk factors in the home. And so that sparked law enforcement to head down an entirely different line. I think the point of that is that screening, it has a good place. I mean, there is a good place to use it if it's used appropriately, but would we have ever signed a death certificate off of that? Absolutely not. And I'm sorry, I don't have the results right here in front of me where I tell you what they were. But the point is that it helped us. But in the end, confirmatory testing is what's going to make that case in the courtroom, just as Rob said, and making sure that we are able to meet all of the legal requirements on what those levels were.
Excellent. And kind of the second part of that is this benzoglycine, the cross-reactivity false positive results. Mention that as well as with THC. Can you go maybe a little bit more into that cross-reactivity process, either one of you?
Well, I'll start, Rob, and then you can be the toxicologist, because I'm not a toxicologist, I'm a coroner. But what I know is that we were getting false positives. And so I don't understand all that aspect. I'm assuming a lot of the viewers here, you're not toxicologists, you don't understand that either. But what I know is I want to get it right. And so we see it, we know as we've compared our confirmatory testing, we know it's a false positive. And so therefore that's just more evidence that this is a myth. You don't need to do confirmatory testing. But Rob can probably give us the toxicology scientific explanation.
Maybe. Well, we do know that for each immunoassay, there's a series of compounds and that will cause false positives. For THC, there are some antidepressants. There's some other compounds that could cause a false positive. Cocaine, benzoylecgonine, cocaine is actually a pretty hardy assay, at least the kind of immunoassays we use in our laboratory, which are different than the ones of point-of-care devices. So they may have more frequent cross-reactives than we would see with cocaine or benzoylecgonine, which is a metabolite, an inactive metabolite of cocaine. But the cross-reactives, they're hard to predict. And the more compounds that somebody has in them, and today it's not unusual for us to find somebody who has 5, 6, 7, 10, 12 different things in them, the more likely there is for a cross-reactive to happen. We can't test everything in the laboratory in terms of cross-reactivities. So we all often are uncovering new ones almost every day that, why is this test positive when this person doesn't have this substance in them? So I also want to make one caution, however, that if you have a screen and it's positive, laboratories, and I'll be forthright, any laboratory that tells you they don't make mistakes is lying to you. So maybe there is a screen positive and the lab just missed it. It's unlikely with these kinds of compounds. Labs generally do really well with the drugs of abuse. So, but you always you should question your lab too. Don't forget to do that.
Excellent. Thank you both for that explanation. This one is a little bit of there's a long example in the chat, but the first question is, are there any cases that you, directed to Bobby Joe, are there any cases that you would use Randox for that you would not send out for any confirmatory testing? One example that has been discussed is in regards to potential cases of suicide, where the cause of death is rather obvious, that it was, maybe some drugs were on board, but was not the primary. So I'll let you expand on that.
Yeah. So in my office, we do full autopsies and we send off for confirmatory testing on all of that. I recognize that in some jurisdictions, it's a resource issue. It may be that you are a long drive to an autopsy facility and maybe the cost of autopsy, it's not in your budget. I understand all of those. We are going to try to function up into the national standards and do complete and send it off for complete testing. It may not have anything to do with cause of death. I've heard that before. Well, it doesn't have anything to do with cause of death. Their cause of death was from a gunshot wound. It has a lot to do with their circumstances, has a lot to do with public health. It has a lot to do with other things that are related. And so I guess the question is, what is our role? Is our role just simply to sign a death certificate and determine a cause of death and a manner of death? Or is our job bigger than that? And it's to have an impact on public health, the criminal justice system, and the emergency management system. Well, I think it's the latter, not the first. And now that takes a lot from some of our communities don't have those resources, but sending off for confirmatory testing is the best method, in my opinion. And I highly encourage that even if you're not doing it, start doing it. Your councils and so forth will follow your lead on what's important. And so we do that on all of those.
Excellent. Thank you for that. I think it's fascinating too to think about when you talk about cost in regards of public health and preventing these types of situations from happening before, right? Like as you mentioned. So ensuring that you all or your office is providing the most correct information to
Correct.
hopefully limit these types of deaths and
I think public health in the coroner medical examiner world is sort of a new phenomenon. I mean, not so much maybe in some of the medical examiners' offices that are bigger, but in the coroner's offices. And we impact public policy. We hugely the criminal justice and public health policy. Well, where does that come from? It comes from the information that's on the death certificates. Well, where does that come from? It comes from our investigations. And so if we do a non-thorough investigation and we don't confirm testing, then we just screwed up the death certificate. Again, I'm just going to talk coroner and be blunt. Then we just screwed up the national stats. We just screwed up public policy. So do the confirmatory testing. It's the right thing to do for forensic science. It's the right thing to do for public health.
Excellent. Wonderful. Thank you for that. The next question is, can you expand a little bit more on the potential benefits of using a customized panel for the Randox multi-stat?
That's probably coming towards me because I said we were kind of working with them, trying to figure out a customized panel. And part of that had to do with some of the novel stuff coming out. That if we know we're seeing a lot of xylazine, well, can we change that panel and you include xylazine in the panel? Or whatever it might be. Some jurisdictions are seeing some things that others aren't. That was a method for us to try to see if there was a way to improve it. I think there's always a way to improve. And so coming up with new solutions is a good thing. Will it work? I don't know. But we've asked and we'll see what happens.
So I can throw in a comment with that. Customized panels, I think, are very good. They're a really good idea. The problem as we see it, say in our laboratory, that's a wide breadth of testing laboratory, is that these compounds come and go. They're almost like faddish in some ways. And that what might be really prevalent for 1 month, 1 week, or a few months is gone and replaced by something else. And while we can easily adapt to that, it's really hard from an immunoassay perspective to adapt to that, because you might have to create a new immunoassay, and that takes time. Whereas we can just add it to our test, and that's pretty quick. So there are pluses and minuses to it, but I like the idea of customized panels. I think that's a really good idea, as long as you're focusing in on the right things, for sure.
I do want to comment on interpretation of the Randox results or Rapid Tox results, and also interpretation of results that are sent to other labs. I'm aware in my state of an office that got lab results from our state toxicology lab. It did not come with interpretation, and they did not do an autopsy, so there was no forensic pathologist, and they didn't have it right. They missed the xylazine that was in there and missed putting it on death certificates. You need interpretation, whether it's a rapid unit or it is a sending to a lab. We've got to have interpretation. And so this should not shortcut any of that.
Does that mean I have job security?
You do in my world.
I think so. Excellent. Thank you so much for that. So we'll move to the next question. It says the continent benefits from several protective factors. Do you think this is accurate based on the situations and established report? Yes, I was okay. I was like,
answer the question. I'm so sorry.
Yeah,
that's okay.
I'm not sure.
There's a part 2, so let me read that and see if it helps a little. And to our guest, if you could maybe clarify your question, that'd be great. But I will read part 2. It says, according to the scientific director of the European Monitoring Center for Drugs and Drug Addiction, his name is Paul Griffith. He says prescriptions for painkillers are better regulated, and fentanyl is very rarely prescribed. Heroin use is less frequent among young people, and access to substitution treatments for this drug is easier since certain analyses. Do you agree to these statements?
Well, absolutely. I agree with that. The most recent statistics show that fentanyl, at least in the States, it's very different. Geographies are very different around, not only within the United States from state to state, but certainly around the world from country to country. what's prevalent in one country may have nothing to do with what's prevalent in another. But at least in our country, what we're seeing most recently is that fentanyl is on the decline. We've seen we keep very careful statistics here, along with a couple of the research facilities we deal with, that fentanyl is declining, which is a good thing. It is a good thing. A number of other drugs of abuse are declining. However, we think this is something that has an easy fix, but it doesn't. Man has been abusing substances since recorded history. It's not new. The substances change, but it's not new. And the problem, as I see it, is it's a matter of demand. As long as there's demand, right, these substances are always going to exist. And while we might see some ebbs and flows in drugs and replacements of some with others, as long as there's a demand, right, you're going to see these substances, and you're going to see abuse. And one could reasonably ask, well, when do you run out of people, right, who are abusing? I mean, it's a reasonable question, but I don't think you do. History has shown that you don't. So I think it is true. Things are on the decline. Other things are on the rise. But it's one of these things, ebbs and flows and ebbs and flows. And I think that follows mankind almost since the beginning.
Excellent. Thank you. There's another question. Have you or are you aware of any research that's considered the presence or absence of genetic markers, how they affect metabolism of different drugs? And this is in regards to determining an overdose. So I guess, are you aware of any research that has looked at those components?
Sure.
I have not.
Of course, there have been many reports on this. The problem with pharmacogenetics, which is what is being spoken to, is that we have a lot of redundancy in us. So the idea that genotype equals phenotype really isn't necessarily true. And that's why pharmacogenetics in the field of medicine, but for a few designated compounds where there are some black box warnings, really hasn't grabbed hold as we thought it would. We thought that was going to be a big part of personalized medicine. And, you can envision where everybody has a little chip implanted behind their ear, and you get a prescription, you go to a pharmacist, and they screen it, and it has your whole genomic, pharmacogenetic background, and they say, oh, you can have this, you can't have this, you can't mix this with this. It hasn't panned out. It has a lot of promise. There was a good paper written by Steve Wong and his group about the pharmacogenetics related to fentanyl and trying to predict, what may have happened to somebody. But we all have to remember genotype, which is what your genes are, right? That's what pharmacogenetics will tell you, doesn't necessarily equal phenotype. In other words, how you express things. So as long as you have that caution in mind, you can use it, but just be very, very careful.
Excellent. Thank you. We did have one more question. Dr. Elvis, if you could clarify your question a little bit, I'd be happy to answer it. But as we close out, I guess, do you have any take-home messages for MEC offices that either have this system in place and are looking to really capitalize on its usage, or advice for offices that are considering getting this type of technology?
I'm going to leave that with Bobby Jo. She has done a phenomenal job of that already, and I think she could probably summarize it nicely for everyone.
Yeah, again, I'm like everyone else. I was looking for a solution to try to solve a problem. But what you don't want to do is create a bigger problem. And so you're going to create a bigger problem by just getting a unit, thinking it's going to solve everything. It's going to cut down your time. And all of a sudden you just fix the world. Well, you didn't just fix the world. What you did is you created a different problem, and you're still going to have a solution to that problem. And so again, I'm all for rapid tox. I love my unit. We use it for public health surveillance. We use it for information for our community. We use it to help us screen and to get information, just like the baby case. But I also know it is not 100%. And again, the question becomes, what percentage are you okay with being wrong for your community? My amount is 0. I want the public trust. I do not want to be on the front page of the paper, and I do not want to be in the courtroom trying to explain why I made a decision that didn't match the scientific standard. And so each will have to make their own decision. I've warned you, but there is a place for it, but it has to be used within its limitations, and you need to understand that. And so with that, I'm glad to, people can reach me offline if they want to know more about what we're doing. Again, this isn't a negative to rapid tox. It is a negative to not understanding the pros and cons of it.
Excellent. Well, thank you both so much. And thank you to our audience for that engaging question and answer session. Their contact information is listed on the on the slide here. We also want to continue to highlight the rest of the Mythbusters series, which will continue on October 17th. Discussing how to find and locate next of kin. And then the webinar series will end on November 7th, where we look more at the usage of MDI related data and how to really capitalize that for your office. So thank you all again. As always, be sure to follow our newsletter for updates and more information. Thank you.
Thanks, Bobby, Jo, and Rob.
Thank you.
As you depart, we kindly ask that you take a minute or two to complete our post-event questionnaire. The link will be pasted in the chat and also appear as you exit the Zoom room. Your feedback helps us improve our outreach efforts and continue to provide the best experience possible. Thank you again for attending, and we hope everyone has a great day.